Welcome to our weekly series of Healthcare Seeing Google Plus Hangouts, where we sit down with the top leaders in healthcare IT. Before we begin, I want to remind those watching to tweet any questions you have to the account at EHR and HIT, or feel free to leave them also on the Google Plus event. If we have time, we're happy to incorporate them into the Hangout and get you some answers. Today, we're excited to have Marc Probst, CIO of Intermountain, also a member of a number of important health IT committees in Washington, D.C. We also have Mike Raymer, Senior Vice President of Solutions Management at M Modal, and Dr. Jonathan Handler, CMI of M Modal. I'm pleased to have each of you here. So
Thanks.
Let's start off with Marc. When I heard you speak a number of years back in Las Vegas, it was right after high-tech was implemented and you were working on the committees in Washington. I was surprised to hear that Intermountain was doing 0 CPOE at that time. So, what is Intermountain doing with CPOE today?
Well, we're just showing how successful meaningful use can be. So we waited until the regulations came out to do it. We're doing a lot with CPOE right now, both inpatient and ambulatory. Of course, we build our own systems, so we've built our own CPOE systems to meet those needs. When we were putting that together, John, and I don't know where we were with M Modal at the time, but when we were talking about CPOE, one of the real concerns was adoption and how accepting CPOE would be by our clinicians. And so really before we decided to go down the road of building our inpatient system, we were doing it with considering the whole time that we wanted a voice-activated, a voice entry process. And it was just kind of fortuitous. We hooked up with Mike Raymer at the time and brainstormed the things we're working on now. But right now, to answer your question, we're doing a lot with CPOE. We've certified our systems and very well.
Great. So, I mean, obviously there's a bit of demand for CPOE with meaningful use. So it's interesting that you went 3 to 4 years ago from 0 to now using one of the first CPOE iOS apps with M Modal. So Mike, could you tell us, how did this relationship come together, and where do you see this app headed?
The relationship came together just because good relationships that existed in the industry. Mike worked with the previous life, and he was kind enough to come and show us what M Modal was doing. We were pretty impressed with for a nuanced user as well, so we were pretty familiar with voice and how to use voice for data entry and capture dictation and those kind of things. But we really wanted to find a use case that could help our clinicians around CPOE. I actually had a different use case in mind when we were talking, but it turned out that this was a good initial use case and an area working together we could develop some pretty innovative capabilities. And it worked to the strength that M Modal had. But it really came from our histories in healthcare and the fact that we could align some requirements and needs that we had and align some of the technical capabilities that our companies were bringing to play. Mike, you got anything to say about that?
I agree. It was really a marriage of our technology and Marc's insight into what would maximize adoption of CPOE at Intermountain Healthcare. So as we looked into this area, we were enticed by looking at the amount of verbal orders that still take place in facilities that report 100% CPOE, but 15 to 20% of the orders are still done on a verbal basis, which makes a handoff, and anytime you have a handoff like that, there's potential for risk and error. So allowing the physician to use their voice to order quickly, be able to visually verify on the screen, and then have that sent to the pharmacy, we thought was a great idea. So it was a great collaboration with Marc and his team. As you saw, John, at HIMSS, we're able to show that, and it was really quite the hit at the show for us in terms of expanding what you can do with voice beyond just clinical documentation.
No, absolutely. I think I described it like the magical user experience because I watched as you manually entered the order and the time frame that it took, and then you did that exact same order with voice, in 3 seconds, and it created the same data. So, I think for me that was one of the trends of HIMSS was how do we take an EHR and make the workflow usable and effective for the physician. And I think that's a major trend that we're going to see over the next couple of years, since EHRs haven't really lived up to that usable physician workflow that makes their life faster rather than harder. So what other parts of this EHR experience do you think we'll see voice work its magic, or other things that M Modal is working on? You want to take this one, Dr. Handler?
Sure. Obviously, we started with medication orders, and when you think about that, we can branch off. The nearest branch is to take it beyond medication orders to other types of orders. So laboratory orders, especially common laboratory orders, especially ones that go along with medication order. I order insulin, I probably want to order a recheck of the glucose. If I order, for instance, Tylenol, then maybe I want to recheck the temperature again in 4 hours, something along those lines. So nursing orders, laboratory orders, radiology and imaging orders, obvious things that come to mind. In addition to that, we can start branching out to things like order sets. Oh, I actually specify all of those individual things. If I have a pre-made order set that is all the usual stuff that I do for a patient with a fever, do a fever order set and then review that, in fact, all the elements of that order set are the ones that I wanted, and then submit that. And then branching out further, documentation on the go. I just gave an order, now I want to document why I did what I did. Maybe I might actually on the go document an entire history and physical. And then, of course, the ability to review data. So while I'm out on the go, the ability to review common information. We also think around the area of orders, there's places to improve, and around other areas in healthcare, there's places to improve communication between two clinicians. So, for example, when I do a consult today, very often the consultation order contains minimal information about, why I'm ordering this consultation. You pick up the phone, you call the person. But if we have a voice interface for these sorts of orders, we may be able to provide a great deal more clinical contexts for the consulting clinician. And we may actually be able to hook up clinicians, and we're on a phone already. Maybe we can facilitate the sorts of communications that don't happen as easily today as we wish and hope that they could. So that's sort of a broad range of a number of things that we think are likely areas where we can make an impact, and where voice and mobile really come together and make sense in terms of creating a better experience for clinicians and ultimately, of course, for patients.
And do you really think that it's all going to go through the mobile phone, or is there still going to be a place for desktops, mobile workstations, things like that?
I think there's absolutely going to be a place for desktops and mobile workstations and those sorts of things. Anytime a new tool comes along, suddenly you want that tool to do everything. And what you realize is, as you start pushing the boundaries, right, you start realizing that different tools are appropriate for different jobs and different situations. And what we really want to do, and this is part of what I really love about our partnership with Intermountain Health, is the ability to explore what are the right places to apply this technology. It's certainly not a one-size-fits-all sort of a thing. On the other hand, I do think that today we're not fully leveraging the new technologies that we have in all the ways that we can, and that's what I'm excited about exploring together with Intermountain Health.
So I think there's really a big use for the workstation. Will continue to be. I also see a different type of workstation in our patient relief clinic, but that's really not the point of this conversation. But I do want to put some pressure on my friend Mike. My original work. The original process I wanted to do rather than voice order entry, and I'm not complaining here, I'm just pushing for the next thing. I think nurse assessment is an area where we could absolutely have a voice-driven process. We do this 10 times a day for every patient, every room, every hospital, and these nurses are going to be gathering a that I think we can quickly gather, we can digitize and get right into the electronic medical record, and facilitate their interaction with the patient, and just automate that process significantly. So next on the line, Mike.
Yep. So, I mean, I assume the reason that Intermountain wanted to really create this CPOE app was driven by meaningful use and being able to achieve meaningful use. And I've heard some people say that CPOE is one of the hardest meaningful use measures. Is that what you're seeing at Intermountain, or are you seeing some other measures that are competing with CPOE as far as difficulty?
Well, I think right now with where we are with meaningful use, we are in phase one. CPOE, just because of the level of the requirement, it isn't that difficult. And we've had tremendous uptake in what we've been doing around CPOE. Some of the things that we're looking at, the transitions of care, some of the data sharing between organizations, seem to be a bigger challenge from my perspective than actual CPOE.
Interesting. So, I mean, you're on a number of some important committees in Washington, and we've heard rumors going around about meaningful use stage 4, 5, 6, and 7, that there could be an extension of the idea of meaningful use into the future. What are you seeing as far as where meaningful use is headed? Is it going towards future stages like that?
Well, I don't know that it'll be as highly regulated, and there's certainly, I think it's going to be difficult to tie things like penalties to meaningful use 4, 5, and 6. And frankly, right now we're really focused on, how quickly people can actually get to stage 2 and what stage 3 might look like. It's interesting right now as we talk in the policy committee, and it's Dr. Paul Tang who is chairman of that committee. But as we talk in it, we're really looking at stage 3 as how can we do more about outcomes and the outcomes that can be achieved through meaningful use versus just layering on more and more functionality. And I think it's a healthy conversation. We're having a lot more conversation around standards, and as standards get in place, even the kind of tools we're doing right now with M Modal and Intermountain are going to become much more ubiquitous and will be able to propagate out there in the market more quickly if we get a lot of these standards in place. Some of the orders that Jonathan was talking about will be facilitated again at some of these levels of standards for better defined. So I actually am pretty happy with where the policy committee is moving right now. Again, stage 2 is still a big hurdle. I'm not hearing a whole lot of organizations thinking that's going to be a slam dunk.
Yeah, and I read something just this morning that someone described the process of going through the creation of meaningful use stages, and that like many have been crying for, that there could be even a delay in the next stage of meaningful use. Are you seeing that kind of delay as well, or?
Well, I'm hearing the conversation. I have the policy committee directly into that conversation and bring an opinion out on it, but I'm hearing a lot more discussion around whether people can do it in that period of time. But that would really come from ONC and CMS. Again, we might take a position as a committee, but the actual decision will get made by the government.
Okay. So also one other question about as far as working with M Modal and the CPOE application, did you have to then become site certified for your EHR with their application, or did the M Modal app become certified, or how did you approach EHR certification using an app like the M Modal app?
Well, so the M Modal app, we're still working through some of the security issues, and so that it will be highly used within Intermountain. We're really still in the development stage. We're past development, so we're getting over these last few hurdles. But to answer your question, we had to self-certify everything. So the app and Modal, we have to self-certify as part of our package of applications.
Okay.
And if someone had a vended solution, actually it's a better question for Mike and Jonathan as to how that might impact their vended situation.
Yeah, so Dr. Handler and Michael, are you guys looking at becoming, taking this product and getting it certified as a certified EHR, or what's your approach to that?
Yeah, our approach is modular certification. So we do not provide a complete EMR. There are portions of the EMR that we can help supplement. So within the regulatory framework, there was this allowance for commercial providers to certify only modules of their application. And so in the case of Mark, because of his environment, he needed to do site certification because of some of the self-developed components. For those that have a commercial environment, they can assemble various modules for various vendors in order to attest that they are a certified EHR. And so we'll pursue modular certification.
And it seems like most hospitals are having to do either site certification or some mixture of modular certification. Is that what you're seeing as well?
Yes.
Okay. So, Mark, I can't resist asking another question that I actually asked you when you were in Las Vegas. It was about meaningful use and EHR certification, and I said, why do we have both? Why do we need meaningful use if we have, or why do we need EHR certification if they've shown us that they're meaningful users of the system? And as I recall, your response back then was, well, I lost that battle, which I thought was a a telling answer. But has your view changed on EHR certification ever since implementing it and seeing it in action, or how do you view it?
So my view on certification all along has been more as a FDA seal of approval, or whatever, that what you're purchasing will do what you need it to do and what the vendor is saying it will do. And my view remains the same on that. I think there needs to be a level of protection for these people that are spending millions of dollars to buy and implement these systems, that they'll do what they need to do so they can get this incentive money. And the fact that ONC just decertified two companies, I think is meaningful. And I don't know what it's going to do for the people that purchased it. It puts them in a difficult situation. So to answer your question, it's changed a little. I see why certification is useful. I still don't know that the approach we took to certification is exactly how I would have done it on my own. But there's value to the certification process, particularly as it relates to the purchasers of those systems, knowing that what they buy will do enough so that if they'll use the system and use it meaningfully, they can get the incentive money and upgrade.
Yeah, interestingly enough, there were no purchasers of that system that got decertified. So luckily, no one's in a lurch. But I think there also was announced an EHR Code of Conduct that was announced recently. I guess that doesn't necessarily apply to you, Mark, right? Since you've implemented your own. Have you seen the Code of Conduct that they've released? And did you see that?
I have seen it, and it's a good reference. It's good reference material for us, but you're right. We don't have to.
Mm-hmm. And has M Modal seen it? Are they looking at adopting some of the principles? I mean, obviously some may not apply since you're not a full EHR, but do you agree with a lot of the principles that are found there?
Well, we certainly take very seriously our responsibility for the security and privacy of the data for which we're custodians of. So we provide clinical documentation services to over 200,000 physicians in the U.S. So we're certainly taking a look at those. I felt on first glance that we were in very good shape as a company relative to those standards that were articulated.
Interesting. So one other question to kind of wrap this up. The other, I think, big news that came out of HIMSS, I think, was the whole CommonWell alliance of exchanging health information, and obviously there was a number of large players there. Mark, how do you think this plays into someone like Intermountain, especially where you have your own EHR? Will you interact with CommonWell, or have you had any of those discussions?
I've had discussions with Cerner around the strategy of CommonWell, and I was a little bit of a vocal critic of CommonWell initially, because it sounded a lot like a more like a marketing campaign and an actual strategy for achieving a good exchange in the future. And I really haven't come too far off of that. The one thing I will say is anything that promotes better standards-based exchange of data is helpful for healthcare. What I was concerned about and remain concerned about CommonWell is going to create another standard. We've got the national standards, we've got standards that we're actually involved in something called the TCC, in the national exchange that we're going through. And if we end up with another 10 standards for how to exchange clinical data, then again, we really don't have a standard. So it depends on how CommonWell works with others, how others work with CommonWell. But the challenge here isn't how to share clinical data. We have CCDs. We understand Link and we understand SNOMED and a lot of these standards that exist out there. It really comes down to selecting a standard and everyone agreeing to do that and then agreeing to exchange with one another this clinical data. So I'm a hopeful skeptic of there's such a thing as a hopeful skeptic.
Yeah. Well, I know Intermountain, they don't quite own the entire market they're in, but they own a large portion. I know as a kid I went to Intermountain and got great care. But I know even despite having such a large market share, I know you've had a number of initiatives where you've worked with the community. I think the first one I saw was the exchange of prescriptions. I think Utah was way ahead in that area, thanks to Intermountain. So it sounds like it's a similar trend. You just want to make sure the standards are similar. Does that make sense?
No, similar. I'd like them to be exactly the same. Either way, you're still a kid.
Yep. All right. Well, I thank you so much, each of you, for taking the time to be here and sharing a little bit about what you're doing and the future of voice and CPOE and what Intermountain's doing to help take care of their patients. So thanks so much for being here.
Thanks for having us.
All right. We'll have you back again.